You guys okay? Germinal centers. There were some actually tingible body macrophages. I kind of feel like they'll want to test looking for tingible body macrophages. I mean, you know, let's look at the low. Yeah, they're in there, but you're looking at a low power. And really, if you start looking closer, what's a little nicer look, there are some EOs and there's some neutrophils sort of scattered around. Not too many in number, but so you get these.
Why not? Sorry if I can ask. Is it okay if we ask some stuff too?
Yeah, go ahead.
Like, why not like an actual lymphoma, like a B-cell lymphoma?
Could be.
Okay.
Yeah. Could be a follicle center lymphoma, and then we start ordering stuff and everything. So yeah.
They wouldn't be able to give us pseudolymphoma and follicular lymphoma for that, right? Or am I supposed to know the difference?
Yeah, no, you're okay. I think I don't think that they would. I don't know what they do, but I don't think that they would. And I think the key on this is you're seeing some follicles, and then maybe if you saw a couple of, you know, EOs in there. There's not as many EOs as I want in this, and I think that's about as far as you get. I mean, beyond that, I mean, literally, I mean, some of these I even use consultations because then they end up ordering like 8 stains on it, and you know, you know, yeah.
So you went pseudolymphoma because the architecture is such a...
Yeah, that's kind of a low power kind of thing. Let me just go into here and there's some little, see these little small bodies within these areas here? Tingible body macrophages.
In the center?
Yep. Right in there. Let me just I looked through this the other day, and there were some EOs in here, but I won't waste all your time looking for them, but they're in there. That's part of the pseudolymphoma. This one you might have been scratching. Anybody have one on, let me pull this up here. Do you have any thoughts on this? I went kind of straight to this focus here. It's neural. See this kind of wavy? Yes, yeah. This is a traumatic neuroma. Yeah. So, see this little neural. It's got you got to get lost in all this because there's all this other tissue and stuff, and right here you can see a little bit of neural stuff there. The focus I gave you I thought was the best one, and a little more. See all this right here? I should have showed you this focus. It's even better, I think. These are all little nerve bundles. Traumatic or
Usually deep.
yeah, it can be up in the dermis too. But all right, traumatic neuroma. Yes, feel free to just blur it out if you want. You guys, what are your thoughts on this one?
Halo versus melanoma.
This was really basically just a congenital nevus, so a compound congenital nevus, and so within the epidermis there are some sort of, you know, nesting of melanocytes there. The neuropagetoid spread, you know, there's starts and stops. It's got good architecture, and then in the dermis, all these cells are pretty small, round, uniform, and I was kind of showing you around some of the follicles, see how they kind of start going around the follicles, and then they kind of start to sort of, the word is splay, they kind of go like infiltrating amongst the collagen bundles. So this was a compound congenital nevus. Follicles really get in, like right here, this follicle's really involved, so compound congenital. All these cells? Yep. Here's a clue. The junctional stuff kind of gives it the clues. Melanocyte, but yeah, these are all melanocytes. All right. How about this one?
Fincus.
Fibroadenoma. BCC.
Fibroadenoma.
Yeah, this one. Well, this one is just so basaloid, and you've got these sort of intersecting kind of bundles, and those tend to have a lot more sort of stroma kind of surrounding them, stromal changes. But the other one that sometimes people, and it's really different, is a TFI, tumor follicular infundibulum, but they didn't really have this real like basaloid appearance. Like this is deep blue, and I have a TFI somewhere in here, and the TFIs don't go sort of as deep. These can actually go much deeper than this, but.
So is this a pincus or was this?
Pincus, yeah. This next one I've shown probably several you may have seen before, but key point on this one here is that so a pattern. So you know, pseudoepitheliomatous hyperplasia with separative granulomatous inflammation. So when you see that, so really remarkable pseudoepitheliomatous hyperplasia right here, and then here's some granulomatous, and then there is some separative. So when you see that, you just automatically it's got to start thinking about infection, you know. So and then this slide here, it's really classic. I've shown this so many times, but yeah. What's this one here? Blastomycosis. Yep. It's nice to actually see it sometimes.
Yes, it is.
Right. Yeah, I know. Blastomycosis. What's all this stuff? Yeah, so this is,
Tibial neck.
you know, that's fair. If it was a shave of pretibial, I'd just say, hey, this is solitary lesion, so it's focal mucinosis, yeah. Yep. I have a pretibial somewhere in here. Yep. Yeah, that's... this one. So anybody?
Mucinosis?
Yeah, yeah. There's a fair number of lymphocytes in the epithelium as well. This was a case from another lab quite a while ago, but apparently there is some suspicion for MF in the patient, but just a lot of mucin in these follicles. So, yep, that's good. Anyone? Scar. There'll be a few kind of routine ones mixed in here. Scar, horizontal fibrosis, vertical vessels. Angiolipoma?
Yeah.
Yeah.
You guys all good? Okay. There's a lot of calcification. There's even a little focus of ossification within this thing, which I'm not sure if that's, you know, if I've seen that before with this, but anybody know what this material is? Amyloid. Yeah, nodular amyloidosis. This I just got a couple weeks ago, and the patient had a couple of lesions on their eyelids. He was worried about a sebaceous carcinoma. Apparently they look pretty atypical clinically. So this is just all amyloid, so nodular amyloidosis. I found a lot of reports on the eyelids. So. But incidentally, this does look like kind of a secondary ossification. It's kind of a get the pointer here. It's almost really, I think this probably is a little ossification. It's a little like orange kind of with the calcification right here. Maybe.
Compared to colloid material, it's much more like easy, right?
Yeah, the colloid you'll see, I mean, this is nodular, so this is just going all through the whole thing. Really, if you're thinking about comparing amyloid, you might think of like almost like a lichen amyloid compared with a colloid milium in terms of where the location is within the skin. and the colloid tends to be these larger masses of material that sort of have these little fractures within it. So, and then I think I do have a lichen or a macular amyloid. Those are a little distinct globules, eosinophilic globules, more subtle. You guys get this one? Anyone? Hemangioma. Yep. You guys good with that? So a lot of the vascular components, so it's hemangioma, but in these little areas, you see this kind of monotonous cuboidal cells, and that's why I was kind of honing in on. I was trying to lead you in on all these cuboidal cells right here. So hemangioma. How about this big chunk? What do you guys think on this? AKN. Yeah, yeah. It's AKN. And so you get this kind of pustular, follicular, destructive process. So a lot of neutrophils are on some of these follicles. And in a later stage, once it's done its damage, usually you get this kind of chronic inflammation with fibrosis. Let me see if I get a nice focus. This kind of picture where you get really fibrotic. It clinically correlates with the AKN and these little sort of compressed islands of chronic inflammation within the fibrotic areas. So a fully later stage would show this, but this is still got a lot of acute stuff with all this. And you get some free hair shafts. The follicles are all disrupted. How about this one? What's that?
13?
This is 13, yep. I will say this one often throws people off.
Between the...
Yeah, so I think right here. I think it's just a little hyperplastic or cut and cross section. Now this is actually, I think somebody said it's a hypertrophic scar. Yeah. Yeah. It's kind of these whorls, and you see this kind of like whorled pattern, really kind of fairly well defined in some areas. And within it, if you think of the other scar, we saw horizontal vessels and stuff. Well, you do have vessels within these here. You get these elongated vessels. If we go, see, more elongated vessels here. So.
Red blood cells.
What's that?
I use the red blood cells for scars.
Oh, yeah, you can see something, yep. Yeah, like right in here, yep. Scars are partly vascular in nature, so you get some of that. Hypertrophic scar. This one?
Yeah.
Yeah, okay. Good? All right. This one? Leiomyoma? Yeah. You guys all good with that? Okay, yep. Smooth muscle bundles. How about this one? Genital femur extensity? Okay, good. All right, yep. Kind of took you right to the giant cells. I was trying to help you guys out on that. This one everyone wrote real quick, so I think y'all knew this. Clear-cell acanthoma. Good. It's a 15-year-old slide. It's all beat up, but it's still a diagnosis. So this is a rheumatoid nodule. Yep.
You see multiple on one side, but
you can, yeah, definitely. Sometimes you can just have massive ones, and some of these are a little smaller. I've seen some that just almost occupy the entire area, but yeah. I mean, if we were to start to think other things, like GA, but GA is rather than this kind of like, eosinophilic fibrinoid sort of material, is more like mucinous. It's not often GA you get such a nice, you know, like a palisade, like a clear palisade. GA, sometimes you're having to look for it a little bit. So these are usually a little bit deeper down. The palisades are usually a little larger, but it's pretty distinctive. Rheumatoid nodule. This is the one. What was this one? I'm gonna. I have a few slides for you. Yeah, this is Leishmaniasis. Yeah, yeah. I have. I have a few slides afterwards, or Rob put up PowerPoint, and I'm going to show you some of the difference between that. So, yeah. But, you know, kind of the theme, like we saw that blasto earlier, you got the pseudoepitheliomatous hyperplasia with, you know, a lot of inflammation, some areas of granulomatous inflammation in here. So, you know, then it's like a bug search, basically, when you start to see that kind of pattern. Just one of my patients. This one? Morphia? Okay, good. This one? Schwannoma, yep. Nice Barrack bodies and stuff. You guys all good with that?
Mm-hmm.
All right. How about this? Yeah, pretty much that family. Urticaria. So, yeah. Yeah. Good? All right. Yep. Through the planet. This one.
Digital fibroma.
Yep. All right.
So is there a digital fibroma? Period. Because I like have gone down this rabbit hole in Reno for some reason because I thought they accessed that at the AD.
Unless it's like a you know, periungual fibroma.
Okay.
Like what's the other word for that? Conans.
Okay.
Cadence.
But no.
Yeah, yeah. What's that?
However you want to.
Yeah, yeah. I don't know how. Yeah. So. Okay. Yeah, but I think that would be different though.
Okay.
Yeah. Yeah. You got into it with someone over that?
Hmm?
You got into it with somebody over that?
No, no. Sigma was also like, I've never heard of that. I'm like, well, I always thought it was only to do with fibrokeratoma, but then, yeah, she wasn't familiar with the exact words she was.
This one? Tragoedia, yeah. Reticulated basaloid lobules, fibrotic stroma. This doesn't happen to have horn cysts, but that's the other third part of the triad. And this. Yeah, it's pushing IFK. I think I called this irritated SK, but it's kind of, yeah. It is a bit endophytic, but I tend to kind of, I think this is actually, I think it's more like irritated SK, but squamous eddies. How's this? Cystoma. This one? Good? All right. Yeah, okay. Small strands of basaloid cells, horn cysts, calcification is usually a pretty common finding in that. This one here, I think I got a bad cut. That's why I kind of paused on this thing. But did anybody pick it out? Yeah, it is foreign body, and there's little actually fragments of suture in here. Yeah, suture granuloma. Where was that one? I ended up searching for it. I think I was honing in on a little area that. Where did that go? Yeah. There actually are little, I wouldn't expect on a test or anything. Usually it's more, they're going to be more obvious. There was another little fragment I had in one of these cuts. It was a little more obvious, but there are actually little fragments right in here. Not the best example, but this?
Tumor?
No, I can kind of sort of see, you know, that it's well defined, you might think, but let me give a clue here. This is mucosal epithelium right here. Mucocele. Yeah, mucocele. Yeah. This is kind of a and this is a big pool of mucin right here. Yeah, so this sort of patterning of it with all this pools of mucin with some residual strands of stroma between it and some inflammation, fairly well defined. It's pretty good for a mucocele. Mucosal epithelium, nice clue. How about this one? What's that?
Facial.
Yeah, I'm hearing it. Yeah. Lupus miliaris disseminatus faciae. That's right. Yeah. Granulomatous rosacea in my head. So yeah. This is a good one. Yeah. How about this? You know, this was just, where was this from? This was a solitary lesion. It was just a calcinosis cutis. Yeah, I'm not sure if we ever, yeah, just a calcinosis cutis on this one, yeah. Sometimes we get osteoma cutis, heavily calcified, and you see a little rim of sort of orange at the edge of the calcium that you think, well, maybe this is really is just osteoma cutis. And I think I had paused on this one thinking that there was maybe just a little rim of this sort of eosinophilic, and you almost feel like there's like almost like, you know, like the fatty of the bone marrow. You almost feel like you're getting some of that, but anyway, close enough for calcinosis cutis. How about this one? Massons, right? Intravascular papillomastoid hyperplasia. Yep, Massons. That's a good one. Good? All right. How about this? Granulation tissue. Yeah, so, yeah, you get some ulceration, and then the vascular proliferation, which is a big hallmark of granulation tissue. Really, you get a really kind of an edematous stroma, and then just a mixed infiltrate. Pretty classic picture of just granulation tissue.
Is that fiber mature vessels?
Right here? Yeah, these are all just little vessels. All this right here?
Yeah.
Yeah, just vessels. They're kind of congested vessels. So, all throughout. All right. And this one?
Eruptive syndrome.
Eruptive, yeah, you showed me. I kind of took you to that extracellular deposition as well. So, eruptive xanthoma. And this? Mets, yeah, metastatic carcinoma. I've got a few of these. I can't remember. I think this was breast.
Carcinoma, playoffs.
Yeah, this was, I wonder if this was my patient who had Poderage. Yeah, Indian filing, atypical hyperchromatic cells, between the collagen bundles, metastatic carcinoma. How about this? EAC, yeah, this is real nice, yeah, so EAC. Just regular EAC. There's superficial subtype of EAC that can really look, so the superficial subtype of EAC starts to get some kind of spongiotic, parakeratotic stuff. It can look almost identical to like pityriasis rosea, or even a spongiotic dermatitis for the superficial subtype of EAC. But straight EAC right here. So cuffed lymphocytes. This one I was kind of debating whether to put it in here because it's a little bit of a, this was a little bit of a weird case of clinical and stuff, but there's some vasculitic change in here. I don't know if you appreciate that when I was kind of honing in here.
Yeah.
So you might think about a PAN, and that was one of the debates we had. I think we were sort of a little bit on the fence. I passed it around a little bit about whether this could be erythema induratum. And I think in the end, we kind of leaned towards erythema induratum, clinical and all that stuff. But usually when I've seen erythema induratum, you've got the paniculitis and the inflammation and maybe some necrosis, but you also got these little smaller vessels. So this, I thought there's a little bit bigger vessel for erythema induratum, but yeah. This one you had about 5 minutes to look at. PCT, right? Yeah, want to sound smart, you say PCT or pseudo-PCT.
How about EBA?
Yeah, you could, yeah.
EB?
EB.
Where are the roots from? Yeah.
Yeah, not EBA, EB, yeah,
EB.
yeah, yep. Yeah, that's right.
No, I mean, yeah, the non
Yeah.
I was just throwing by EB also. Yeah.
I had a number of naprosins, you know, causing that, like several. Where was that tumor? You guys think on this one?
Sebaceous carcinoma?
Sebaceous carcinoma, yep. There are little pockets here, little rare, like sebaceous, right there. See that right here? Yeah, so, and that lobular architecture. I mean, you might start thinking about other things like Merkel cells. Cells are so atypical in here. They're a little bit kind of smudged chromatin kind of look, but it's well lobulated, and then you get these little areas of sebaceous differentiation, so sebaceous carcinoma. Okay, good. All right, how about this one? Anybody? This wasn't that, but yeah, this was lichen striatus. Yeah. I think this one kind of, I've had some hernia cases that almost had a little lichenoid kind of infiltrate with some superficial and deep, maybe some periacrine kind of inflammation. So, you know that, but this was lichen striatus. Kind of affecting some of the glands down here, inflammation-wise.
You get a lot of backdiagnosis of lichen striatus.
You can get some, yeah. It's not like a hallmark feature or anything, but yeah. And kind of correlates a little bit clinically. This I kind of took in right to the, this was a good example of it, really. So was this, it's got like 5 different names, right? So lipomembranous paniculitis, dermatosclerosis, I think sclerosing paniculitis, hypodermatitis sclerotertiformis or something like that. So, yeah. Just, all right, you guys good with that one? Okay.
What's that last name you said?
Hypodermatitis sclerodermiformis.
Okay.
That's another one, yeah. Yeah, that's, ignore that. Just ignore what I just said. Just stick with the others. We could probably debate a little bit back and forth, but a lot of eosinophils. So, bullous pemphigoid. Should have showed you this without this.
Yeah.
But anyway, this right here is really good for it, right? Accessory tragus.
Yeah.
Little fat in the middle, all these little kind of early hair follicles. Yeah. A nice big clue. CD30. I was trying to point out some of the, actually switch to slides, CD30 positive cells. I was trying to point out some of the enlarged cells in some of the infiltrate. I think right in this focus there was a few. So this is lymphomatoid papulosis, but you can kind of see these few little enlarged cells kind of scattered in the infiltrate. But and then there were some newts, eosinophils, kind of mixed in, ulceration, you know, the OIP lesion, self-necrosis. How about this? Alopecia areata. People, yeah, I get biopsies for AA. It's like, I feel so lucky if I actually find it. And then we end up running cut after cut after cut, and you know, and this was one I think of several slides and in one little area, but this one here, scleroderma, yep. I tell you every time, it's my neighbor. Yeah, he's got this big ruddy back. And then when I went to stitch it, I'm like, ah, jeez, you know, we're going to just let this open. Yeah, just a joke. Scleroderma, thickened dermis, a little bit of mucin in there, not much really inflammation. Gel foam, yeah. Anybody have any thoughts on this one? You're thinking, yeah. Syphilis, you know, with a psoriasiform lichenoid approaching, it would enter my thought on that. Not really as like histiocytes in the infiltrate. Usually it's a little bit more epidermal hyperplasia, but it's a possibility. But there's some interface change on this. Occasional necrotic keratinocytes, a little bit of lymphocyte exocytosis. So this was a pityriasis lichenoides. Junction's kind of blurred. This one I had to dig deep to find, but 2002. Is anybody able to pick this one out?
Yes.
What's that?
Yes.
Go ahead.
Nodule fascia.
No, yeah.
In the air bags, but it's too deep.
Yeah, and it's, you know, those are usually more kind of almost like spindle cell tumor, crazy atypia and all this. So this is a cutaneous lesion of Rosite-Dorfman, sinus histiocytosis. Yeah, so sinus histiocytosis, massive lymphadenopathy, and the big thing is really a big, dense, sort of nodular infiltrate, and right here with all these histiocytic cells in here. And I would say that this kind of low power, where you see that kind of little clear space, you see how it's like almost like a syncytium of these little clear spaces with some lymphocytes and other cells mixed in. That kind of picture that you see is pretty good for this. And then I think maybe what you might want to do is go online and just think about this, and then look at, because I think this was on, I can't remember which exam it was on. This is on something for me. Of course, that's a long time ago. But and you go look online, look at a few of these, and you get a kind of a feel for that. But the big thing with Rosite-Dorfman is these histiocytes start to engulf all these other cells, and they can engulf red blood cells, so it's like the erythrophagocytosis, or other inflammatory cell lymphocytes, and they call it emperipolesis. So
And Langerhans cells is really more superficial.
Yeah.
Yeah.
Let me see if I can find. So here's a histiocyte that's eaten the lymphocyte. Right in here, you see that pretty enlarged histiocytic cells. So that's what's they call it emperipolesis, I think was the term. Maybe over there. These pretty large cells. And then these large, pale histiocytic cells right here. And when you go on low power, you can kind of see, okay, that's what those pale areas are. So. This one, psoriasis, okay.